Hello, everybody. Welcome to this online seminar. My name is Marcio Garcia dos Santos. I'm part of BEGO Implant Systems education and clinical research team, and I will be the moderator of today's session, organized by BEGO Implant Systems, our distributor partner in Iran, company TT Pass, and Isfahan University, which is represented today by Professor Bijan Movahedian. First of all, I hope that you and your family are all in good health. Today's topic will be guided surgery out of the box, introduction to the media team workflow, and the speaker will be Dr. Andreas Barbatseas from Greece. Before welcoming our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Marketing Department for the organization of this session, and I will give the words to Professor Bijan Movahedian, whom will open the session. I believe Professor Bijan had a problem with the connection. So then I'm gonna present our speaker, is Dr. Andreas Barbatseas. Dr. Barbatseas is graduated from the Dental School of the University of Athens, Greece in 2005. He received specialty training in surgical and prosthetic implantology in the Department of Periodontology and the implant dentistry of New York University, USA from 2008 to 2010 with Professor Dr. Dennis Starnow. In 2010, he received the New York University's Postgraduate Research Award for his research work on peri-implant soft tissue management. Dr. Andreas Barbatseas is the founder and director of education of the Media Team International Association, which mission is to provide state-of-the-art digital services relative to computer-guided implantology and state-of-the-art specialized clinical courses relative to advanced implant dentistry to dentists worldwide. Dr. Barbatseas has been the winner of multiple clinical awards, including the first BEGO Clinical Case Award in 2013. Dr. Barbatseas is an international speaker on advanced oral implantology and oral microsurgery, having trained numerous dentists from all around the world with innovative lectures and courses. He maintains a private practice in Athens, Greece, which is limited to implant surgical reconstruction and soft tissue regeneration, and since 2020, he is the director of the Media Team Digital Center in Greece, which offers advanced digital service to dentists on an international basis. Andreas, my big friend, thanks for accepting the invitation to conduct the session. As always, at the end of the lecture, we will have a question and answer session, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time and give the words to Dr. Andreas Barbatseas.
Hello, everyone. Marcio, thank you very much for this invitation, and I hope that Professor Bijan can hear us. I would like to thank him also. A big thank you to our colleagues from Iran that joined this wonderful meeting, this wonderful webinar organized by BEGO Implant Systems. And BEGO is always doing a fantastic job organizing online events or physical events. They always do a great job. Physical events, I know we all miss them. I miss them too. Haven't had the chance to visit Iran yet, but we can probably organize something in the future in Iran. Of course, when things will start to get back to normal, hopefully soon. Fortunately, however, we have this technology here, the digital technology, that is the topic of our presentation. How can we use this technology to make our lives easier, to make our lives better, to, as dentists, to plan implants digitally and place them through surgical guides? I know that many of you must be thinking that This presentation is probably, you have heard a lot about this topic. It's a very popular topic, guided surgery. I have also attended numerous seminars about this topic. It has to be a little bit different. That's why this topic is called guided surgery out of the box. So what do I mean by that? Out of the box, this computer that you have in front of you is just a box. And if you take one thing from this lecture, I want this to be it. Don't ever forget that this box is it's a very nice box. Looks magical. It can do a lot of things for you, but it heavily depends on the things that you put inside. So you put good things in, you take good things out, and of course, the opposite. My perspective about guided surgery, I believe that it's quite interesting since I started being an analog guy. I started being very hesitant to enter this world of guided implantology. So not long ago, feeling very skillful with my hands, I really didn't want to lose my freedom by following a surgical guide. I felt that if I needed to follow a surgical guide, I'm going to do a blind surgery. So I was the type of guy that I have a drill and a handpiece in my hand. Give me a treatment plan, I can do it. I don't need a surgical guide. In a way, I am a little bit like this still, but of course, a lot of things have changed. Guided surgery is a big part of my daily practice today. We even have, as Marcio said, we have our own digital center here in Greece, the Immediate Digital Center, working with BEGO Implant Systems exclusively. And of course, we use only the products of BEGO, which is the company that we think we have to use for multiple reasons, of course. So in 1 hour, I know it's very difficult for me to give you the whole story, to give you every practical information needed to start tomorrow, but hopefully I will try to give you the main reasons which made me change my mind and the key points of my perspective in this very, very interesting topic. So I would like to start by sharing with you the way it all started. More than 30 years ago, in 1988, when my father opened his private practice, he took this painting that you see in your screen. This is one of my favorite paintings, and he put it on the wall. And I grew up as a child walking around the practice, watching at this painting, and it looked funny. You know, to me, it was very funny looking at this skinny dentist working on the virtual screen, on the virtual teeth. It's not funny anymore, right? It's really not funny anymore. This is what we do. I mean, it looks cute, but it's not funny. This is our reality. This is what we do on a daily basis. And even these cables that run through the chair and going into the dentist's back, even these cables, I don't know, maybe we'll have to wait for a few more years. So a lot of things have changed. Today, this is what everybody wants to do, guided surgery, and it doesn't really matter if you just begun your journey in implantology and you have placed a couple of implants, or if you have placed thousands and thousands of implants and you are what we call an expert. Doesn't matter, you are invited in this tour, you are invited in this train of evolution, and basically guided surgery is promising the next step in your career. It's promising that basically if you want to do something better, if you want to do something different today, it has to be digital. This is the trend. Okay, so before going into this train, the first thing we need to understand and make clear in our head is why should we do it? This is the question that I asked myself when I started. Why should I do it? It's very simple, right? So first of all, we have to consider if we're doing the best for our patients. So if we use guided surgery, for sure, we have to improve the things that we're already doing. This is the first thing that we want from guided surgery. The second is to do more things, is to do things that we can't do without using this technology. Improving the things that we're doing, and of course, adding more treatments for our patients. And these two things are different for a beginner and of course different for an expert. Expert in what? In implant surgery. And if you ask me, according to my own subjective criteria, there are not too many experts in implant surgery today. This is what I feel. Because an implant is not just a screw that you put after you drill a hole in the wall. It's not like that. It doesn't work like that. When you're drilling this hole, this osteotomy, you have to think about so many things, biologically related, prosthetically related, aesthetically related things, about the bone, the soft tissue, the interrelationship of the adjacent teeth and implants, and of course the overall treatment plan. All these things have to be in your mind when you're drilling. So implant surgery is not an easy procedure. And of course, if you are one of these very few experts, then you might say, okay, guided surgery could be a very helpful alternative for my demanding cases. So if you have a case that is a full mouth case or a full arch case, or an aesthetically delicate case where you have to improve your precision to be faster, and of course to decrease the trauma for your patient, for example, place the implant flapless, which is not easy, even for an expert. This is not easy to place an implant flapless with precision, of course. Then you might say, okay, yeah, guided surgery could be a very good idea. Now, if you're a beginner, if I was a beginner, right, and after placing a couple of implants, somebody tells me that I can have a guide to help me during implant surgery, I would say, of course, I need this guide for every implant, for every case. So a beginner might want this, this alternative for every single case. And this, of course, opens the discussion, which to me is interesting. Since a beginner can basically have a guide for every possible case that comes in his or her practice, is it the right thing to treat even complex cases just because guided surgery is available? And this, of course, is something that we will touch a bit during this lecture. I will share with you the very first case, my very first case in guided surgery. And of course, when this patient came in my practice, I was not a beginner. On the contrary, it happened just a few years back. But this patient made me feel like a beginner. And you want to know why? I understand. So I will share with you the reason. This patient is my mother-in-law. So my mother-in-law came in my practice saying, Andreas, you are an expert. I have heard so many things about you, of course, and I want your help. I want you to do something about my upper right ugly bridge. And I said, okay, it looks pretty simple, 3-unit bridge. She says, yes, let me tell you what we're going to do. Interesting. Your mother-in-law comes in your practice and starts giving instructions. So she says, yes, we have a 3-unit bridge. I would like to have a single crown for the canine, a single crown for the second premolar, and a single implant in between in the area of the first premolar. So I said, fine. It looks amazing. It's a great treatment plan. I couldn't even plan it better. So she says, yes, but there's always a but. There's always a but. So she says, yes, I have made a little bit of research, and I have heard about this new cool stuff where you can use a surgical guide, something like a plastic thing that you put in my mouth, and it helps you navigate your drill, and it's kind of cool, right? So we can use this, and maybe we can have even the crown, the tooth, ready before the surgery. And I couldn't believe what I was hearing. I mean, my mother-in-law comes in my practice and suggests the treatment. And I said, okay, I mean, it sounds interesting, but in this case, we have a 3-unit bridge. We don't even have to load the implant, right? We can place the implant and, of course, create a temporary 3-unit bridge and then load the implant once it's integrated. Yeah, but she says, I mean, you're not cutting edge, right? You can't do it. And as I said before, I was really hesitant. I didn't like the idea of surgical guides and all this. So I said, okay, I mean, it's my mother-in-law, the best patient to start my journey in guided surgery. So back then, what did I know about guided surgery? Not too many things. First of all, the one thing I knew was that I needed people to help me. So at the beginning, it started like this. It was me and my mother-in-law examining her. And if she attends this webinar, please don't be offended. It's just a picture that I got from the internet to be a little bit funny. So we needed more people in the team. Of course, our dental technician. The dental technician has all the equipment needed, a 3D printer, a milling machine to print the guides, the abutment to mill the abutments, print the provisional crown, since we wanted to have it prefabricated in advance before the surgery takes place. But most importantly, we needed someone to connect all the pieces of the puzzle, someone that provides digital services. So I made some phone calls, and after discussing with a few of them, I trusted one of these digital specialists. Let's call him a digital specialist, someone that knows the whole workflow and helps you do it. So he said, Andreas, no problem. Please send me the x-ray of the patient. So I sent him my mother-in-law's panoramic x-ray, and he said, of course, it looks like a simple case, single implant, first premolar. But since you are going to replace this 3-unit bridge, why don't you get rid of it in advance? And of course, if you can also replace the amalgam fillings in the posterior 2 molars on the upper right side, do it so that we can have a dental scan and a DICOM file that is clear, that it doesn't have artifacts. It will help a lot during the process. So I said, okay, no problem. So in the office, we removed the bridge. We, of course, corrected a little bit the preparations in the 2 supporting teeth and replaced the amalgam fillings with composite restorations. And then my mother-in-law had her dental scan. This is the dental scan that that we were able to have, a clean, clear dental scan without an artifact. And this is very important when you do guided surgery. This is your first file that is needed, a clear DICOM file. And I'm sure that most of you are already familiar with this terminology. This is the second file that is needed. It's the STL files. It's the second digital thing that you need to follow this workflow. In simple words, the STL file is a 3-dimensional representation of your patient's teeth. So in order to generate an STL file, you have to scan your patient's teeth directly if you have an intraoral scanner, or of course indirectly. Take an impression, preferably with a silicone material or a polyether material, pull your model, and once you have a model, you can put it in a lab desktop scanner and scan it and have an STL file. And this is what we did. This is the STL file of the model with the two preparations. And then our technician created the two crowns and then placed it on top of the two preparations in the model and scanned it again. So we have a second digital file, a second STL file, having the crowns, and now you can see exactly what is the space for the implant crown in between. Okay, great. Now, we were able to go to the very crucial stage of the whole workflow, which is basically combining the two digital files and superimposing them. And this has to be done with great accuracy. That's why the diagram has to be a little bit as clean as possible without artifacts. And that's the beauty of the whole software. I mean, you can visualize in one screen everything: teeth, soft tissue, preparations, the new crowns, the implant, everything. So basically, you need all this information to plan the implant position. So at this stage, the digital specialist sent me an email, and we were communicating via email back in these days. We don't do that anymore, of course, but back in these days, we were exchanging emails. So he sends me an email, says, Andrea, we're ready. Everything is pretty much fine. This is your implant. What do you think? Can I please proceed to print the guide? So I look at this and I said, okay, I mean, it looks pretty much fine. I mean, it's in the bone. It's a 3.75 by 15 millimeter implant, the RS implant of BEGO. So I said, okay, I mean, it looks fine, but I would like to see a little bit of the prosthetically related information. I mean, can I see something prosthetic? I mean, the inclination of the implant, the relationship of this implant with the implant crown. The whole workflow is supposed to be prosthetically driven, right? It's a blind surgery, but at least we have to know where we're going. So he says, okay, no problem. This is it. He sends me the STL with the inclination of the implant, the orientation of the implant. So he says, okay, are we ready to print the guide? And I said, no, I still don't see the crown. And he says, okay, why do we have to see the crown? It's a simple case. It's a single implant. Why do we have to see a crown here? And of course, he didn't understand why, because he's not an implantologist. He's a digital specialist, very good in computers, but in his mind, he doesn't have all this information needed to plan an implant in every case. And I mean, this case looks simple, but of course, sometimes what looks simple is not so simple. So he says, okay, I'm going to send you the STL with the crown. So he created a crown within 1 minute, sent me another email, and he said, Andreas, now we have everything. This is the crown, this is the orientation, and this is your implant in the bone. Can we please print the guide? So I sent him an email with an answer. If this is the crown that my patient will have, then I will probably have to get a divorce. So he says, I don't understand. Why are you saying these things? And I said, because of two reasons. First of all, this patient is my mother-in-law. Second, this crown looks crazy, crazy short. It's like 2 millimeters shorter than it has to be. And your point of reference is the gingival margin of the second premolar. So it looks very short. And his answer was, okay, I mean, make it larger. I mean, place the implant and then make it larger. And of course, it doesn't work like that. If you want to make the crown larger, you have to sink the implant deeper, right? So 2 millimeters longer crown means the implant has to go 2 millimeters deeper, of course. And we were able to do that. He changed this position because in this case, we need to manage the tissue. It's not about only placing an implant. We need to remove soft tissue, and of course, we need to remove part of the bone. We need to do, in a way, crown lengthening for this implant. So a simple case, single implant, first premolar, not very simple, right? So this is how we started. And of course, now he sends me the crown without me asking for this, and he sends me this. And I said, okay. I mean, we started having a 2 millimeter shorter crown, and now we have a 1 millimeter shorter crown. And I don't understand, why do we have to exchange these emails? So he says, I really don't understand why we have this result. So to explain a little bit, this crown was supposed to be a cement retained crown placed on a cut-come titanium abutment. Why cement retained? This is, of course, not my preference. I like screw retained crowns for every case that I can have a screw retained crown. But for this case, because we wanted to have the crown 100% prefabricated, ready before the surgery takes place, this is not possible with a screw retained crown, of course. So if you want to have everything ready, a cement retained crown is your only possibility, in my opinion, if you want to have a precise 100% precise result. So, or close to 100%, because nothing is 100% in life. So I told him, okay, we need to have an abutment and a crown. Where is the abutment? Where is the design of the abutment? So he sends me the abutment, and immediately I see the problem. The shoulder of the abutment, the gingival, the prosthetic margin of the abutment was at the same level of the gingival margin of the second premolar, which is not what I would like. Of course, you would like to have the prosthetic margin higher, 1 millimeter deeper, 1 millimeter subgingivally in a way. So immediately I asked him, what is the height of the transgingival part of this abutment? And he said, it's 3.5. And we, of course, said, okay, let's decrease it, keep the implant in the same position, and do make it shorter, the transgingival part of the abutment, make it 2.5, and that's it. We're set. Now we're ready. Now, after how many emails? After 52 emails. So back then, for one implant, I needed to send and receive 52 emails. It was, to me, it was terrible. In the same amount of time, I could plan 5 full large cases. Anyway, since we did all this, I asked my technician to design a surgical guide just for the tissue management, just for the soft tissue removal, to be a little bit more fancy, to remove the excess of soft tissue in a guided way. And then, of course, print the surgical guide for the implant placement and print the surgical guide for the tissue management. So now we had everything ready. Of course, we asked BEGO Implant Systems to mill our cut-count titanium abutment and then print the crown, the cement retained crown on top of this abutment. So now we have 2 surgical guides, our abutment and the crown, everything was ready. The surgery was amazing. It was a life-changing experience for me. I mean, simple surgery, 1 implant, of course, but you can really appreciate the difference. Okay, the preparation was going through hell, but the actual surgery was amazing. So we were able to handle the excess of tissue, to remove it in a very, very controlled way, and then place our implant flapless. We placed a 3.75 by 15, as I said, having great primary stability. This is something that you experience in most of the cases that you do it guided. It's very easy to get good primary stability, since your osteotomy is always, your drills are going in and out in the same position. I mean, you don't over prepare. It's very difficult to over prepare, of course, because your guide is very limiting your drilling and your deviations that you can have. And then, of course, you can. We were able to navigate the hex of the implant in order to place a CAD/CAM titanium abutment exactly in the right place, and deliver at the end the cement retained crown, which it was, of course, much easier than having a screw retained crown. A cement retained crown is something that you can put in and out and adjust the contact points, adjust the occlusion, and give the patient a great result in a very, very easy way. So after completing the surgery, my feelings were confused. I was feeling, disappointed by the preparation phase, but I was feeling, a great enthusiasm relevant to the actual surgery. So first of all, I made some conclusions which were very, very important. If you are a beginner, this case is a case for a beginner, right? This case is a case that a beginner wants to do. I mean, it's a single implant, first premolar. It's not a central incisor with excess of tissue. Of course, it looks easy. If I was a beginner, what would be the result? The result would most probably be a short crown. Is it the end of the world? Of course not. But if we didn't have a case like that, and we had a more extensive case, a full arch case, 5 or 6 implants, could I treat it just because I have a guide? I don't think so. Guided surgery is not just the phase of the actual surgery. Most importantly is the phase of preparation. So once you go into and you open the door of the digital implantology and you enter this world, you will understand that it's a different implantology. It's a new implantology. We have 2 kinds of implantology. We have a standard implantology, the regular implantology, the free-handed implantology, and we have the guided implantology. So, of course, you start by being a beginner, and then you gradually gain some experience. You become an intermediate in the regular implantology, and in one day you will become an expert, of course. But guided implantology, it's a different topic. It's a different ballgame, and the rankings, the levels are higher than the standard levels. So a beginner in guided implantology is in a higher level than a beginner in standard implantology. And this is also true for the intermediate and the expert levels. The highest possible level is the expert in guided implantology. And when I started, I didn't know about these things. I said, okay, I mean, I can do everything free-handed. So with a guide, I can do even more things. And it wasn't like that. I really had to reinvent myself, develop myself, become a better implantologist. And this, I would say, is the greatest benefit from this change, from this shift that I made in my career. I became 10 times a better dentist than I was before. So when I started, after completing the case of my mother-in-law, my standard implantology was this. I was able to take a case like that with a failing upper dentition, extract all teeth, and place 7, 8 implants within a couple of hours, take an impression of the implants, and of course, phasable registrations, bite registrations, everything pretty much controlled without a surgical guide, right? This was my standard years. So I was able to do that within 2 hours, take this impression, and then after a couple of days, this was the result, that we were able to have a provisional prosthesis with a metal framework, always with a metal framework. In this case, we didn't have to load the posterior left implant since the patient didn't have teeth in the posterior left area of the mandible. So we didn't load the implant in the posterior left area of the maxilla as well. And then after a couple of months, we were able to take an impression and deliver this final prosthesis with this precision. So I asked myself, do I have anything to gain by doing this kind of cases guided? Because at the beginning of the presentation, this is what I told you, right? That an expert would like to have this guided workflow for the complicated cases, for the difficult ones, for the demanding cases. So a full arch case or a full mouth case, it's a perfect case, but you have to be able to give something better to your patient, to gain something from this guided workflow. Otherwise, it doesn't make sense. If I'm doing it already without the guided workflow, why should I bother and change completely the way that I practice? So from the very beginning, I was very, very demanding. I said, these are my requirements from guided surgery. If I go guided, I want to be more precise than I am. I want to be faster than I am. And of course, I want to decrease the trauma for my patient. Okay, pretty solid requirements, right? Because my dream about implantology is not just to open big flaps everywhere, create a red mess, and have a surgery, in a 10-hour surgery, and then the patient is completely swollen and in pain for 2 weeks. This is not what I want. Success for me is when the patient doesn't even understand that he went through a surgery. So guided surgery is promising you this success, right? As far as the prosthetic phase, because in my mind, these cases are successful when you combine these implant placements with immediate loading. It's very important for the patient. So I would like to have the prosthesis, the immediate prosthesis, the provisional prosthesis, prefabricated. I would like to have this prosthesis ready in advance before the surgery takes place. So before guided surgery, I was placing the implants and I was taking an impression. The impression was going to the lab. So after a couple of days, I was able to have these prostheses. So now guided surgery is promising to me that I would have these prostheses ready in advance. That's great. So this is very important for me. And of course, this prosthesis has to satisfy some basic requirements. It has to be aesthetic, so it has to blend with the face. It has to fit 100% passively with the implants, and of course, on the implants, and of course, it has to be durable. It has to last. It's very important that this prosthesis doesn't break, right? The implants are not integrated. We're talking about immediate loading. So over and over, I see this in the already existing workflows. I see implant placements and then an prefabricated, printed PMMA prosthesis, a full arch prosthesis, placed on the implants immediately after the surgery is finished. My opinion about this is that this is a huge compromise, and people say that this prosthesis doesn't break, doesn't have problems. I really don't believe that. I have seen problems. We have seen these problems, and of course there is a lot of literature out there supporting this argument that this PMMA, full arch prosthesis, anything that has a cantilever or a pontic, and it's not supported by metal framework, it's subject to a fracture. The risk is very much increased. So I really didn't like that. I didn't like to use this guided workflow and have my provisional prosthesis ready in advance without having a metal framework. It was a huge compromise for me. So we really had to dig deep, very deep, reinvent ourselves and try to find ways to overcome the problems of the existing workflows. And take a case like that, again, with the failing upper dentition. The upper teeth need to be extracted and replaced by implants. Of course, the lower teeth need also prosthetic work since the occlusal plane of this patient is distorted, but we will focus on the implant part of this treatment plan, the upper jaw. So this patient needs extraction of all teeth, placement of some implants, and ideally immediate loading with a provisional prosthesis. For me, the success in this case would be to have this prosthesis ready in advance, which is something that I couldn't have before guided surgery. Of course, if you start this journey, you have to really think about so many things. You have to overcome the problems relative to this, to every possible stage of this journey. So you're going to use a guide, right? But where are you going to support this guide? And we know already that mucosa supported guides, which is something very popular, they don't have the same accuracy as tooth supported guides. So for us, it was very important to have the best possible accuracy, right? We were accurate without the guide, so we have to be more accurate with the guide, not less accurate just because the easy solution is to have a mucosa supported guide. Okay, once you have teeth, use the teeth. And we created some abutments for this guide by prepping these teeth. You can see the teeth that will support the guide. And you also see in the posterior left area a metal abutment. This is basically a PI implant. It's a provisional implant by BEGO Implant Systems. It's an amazing, for me, very, very, very helpful solution that BEGO is offering. Temporary, it's a one-piece implant that has the intraoral part of this implant is an abutment which can be used for guide support, or you can support removable prosthesis. You can do many, many things. We use them for guided surgery. And in this case, where we didn't have a stable abutment for our guide, in the left area, we added a provisional implant. So I already mentioned, we will have everything ready in advance, but this prosthesis that we will have has to blend with the face. So this is not possible unless you can really integrate the information of the patient, of the face of the patient into your workflow. How do you do that? We know already that we have facial scanners, we have workflows involving photographs taken from multiple angles. I truly don't believe that we are yet in this era, in the fully digital era. And really, if you ask anyone with extensive experience in treating this kind of cases, the big cases, he will agree with me. A face bow is something that we cannot replace, unfortunately. So this is what we believe. We always have a face bow registration. And of course, after having a face bow, we have an analog articulation of the models. As I said, we take impressions of both arches with a silicone material. We have stone models, which is a very, very important part of our workflow. And then the real big challenge is how can you transfer your analog articulation to the digital environment? This is a very important phase. How can you do it very accurately? Because on this transfer depends the accurate prosthetic plan that you will do, your three-dimensional walks-up, which is the most important part of the whole planning. It's the final result created in a digital environment. So the digital articulation of the two STL files has to be accurate. And of course, this walks-up respects the different planes of the patient, the interpapillary line, the facial midline, the horizontal plane, the commissural line, everything, all these planes have to be integrated into your workflow. And this is, to me, one of the most important things and very, very challenging. There are ways, of course, to test what you're doing, to superimpose the three-dimensional walks-up with the photo of your patient and check if what you have in mind and what you have planned is what you really want to have. So there are many things that you need to take into consideration in order to have everything in advance. And once you start handling the digital files like the DICOM, you see here this patient has a DICOM file full of artifacts. Of course, this patient had prosthetic restorations with a metal framework in all of his upper teeth. So of course, he will have a DICOM file that is not clear. And the challenge is now, how can you superimpose, how can you connect, how can you match the STL from the impression of the patient's teeth with the DICOM from the dental scan? This is a very important phase, right? We said that already. And this has to be done very accurately. And this is not, of course, the only thing. The most important thing is how can you superimpose the digital walks-up that you have with a DICOM file. This is what you need in order to start planning implants. Information about the bone and information about the prosthetic teeth in one file. So we had to develop some protocols relative to the scanning of the patient using special trays with radiopaque markers in order to overcome these problems. And once we connect these two files, the DICOM with the STL with the walks-up, now we can start planning our implants. Now all our knowledge about implantology comes into the game. Now you have to think about implant or positions, angulations, interrelationships, sizes, introducing multiplus abutments to change and correct the angulations. Now here you become an implantologist again. This is the final plan for this patient: 5 implants placed in this specific with this specific orientation to avoid the 2 sinus slits on the back. And of course, then you have to design a surgical guide that is durable and precise, that can really help you during the surgery. The prosthetic planning is even more difficult. How can you really plan the framework, which is, to me, one of the most important phases? You see here on your left part of the screen, you see the blue areas. These are the orientations of the 5 implants, and you have them in front of you, and you design the metal framework with rings going around this blue extensions of the implants. These blue extensions basically represent the abutments that will be placed on the implants. So, and then we have, this is the manifestation, the physical manifestation of the guide. In this kind of cases, in the big cases, we always print 3D printed model with DIM analogs in the exact positions where the implants will be placed. The abutments are placed on the DIM analogs, and then you can test on this 3D printed model the fit of the guide and also the pathway of insertion. This is very, very important. You can check the relationship between the rings and the abutments. Very important phase. That's why you need to have models in your hand. That's why I really feel that this is very important. Just doing it model free, it's not giving you all this information. You have a stone model and you have a 3D printed model, and you check the guide and the framework and the final prosthesis and the abutments. Everything can be checked on something physical. And of course, then you have to veneer the prosthesis, which is also very challenging. How you handle the occlusion and everything else relevant to the prosthetic planning. Once you have everything ready, once you complete all these phases, then we go into the surgery, which is the fun part. When the patient sits on your chair, it's time to start having fun, because the surgery, having a guide like that, is incredible. You extract teeth, place implants through this surgical guide. In half an hour, you can place 5, 6 implants with great primary stability, flapless. Of course, when you can place them flapless, otherwise you can raise very small minor flaps to preserve some keratinized tissue if needed. And then, of course, place your provisional prosthesis on the solid abutments that were supporting the guide. Pick up the abutments from the implants, and then manage the emergence profile of the abutments and the whole general emergence of the provisional prosthesis through the tissues, and everything is ready within a couple of hours, not a couple of days. So you have really invested time in advance, but now the surgery goes fast and the surgery looks and feels easy for the patient and for you as well. And you can really, in a very controlled way, deliver what you really want for your patient aesthetically and of course functionally. You can have a provisional prosthesis with a metal framework, as I said, very important for me. And you see here also the implants placed very precisely, avoiding the 2 sinuses. And to me, this was my first full arch case. I was really astonished with the things that we were able to do. I was able basically to satisfy my personal demanding requirements. I was more precise than I was in a free-handed way. I was, of course, faster during the surgery, investing the time in advance, but during the surgery, which is the most important thing, right, for the patient as well, I was 10 times faster. Being able to deliver the same result in a less dramatic way. Some implants, I would need a minor flap. In this case, I did everything flapless. And of course, I was able to give to my patient an aesthetic provisional prosthesis, 100% fitting passively on the implant, since we picked up the abutments during surgery, a durable prosthesis because it had the metal framework. And the most important thing, the prosthesis was prefabricated. So we were able to deliver this prosthesis within a couple of hours, not a couple of days. So this whole workflow can be applied in every different clinical scenario. Each case is always different, right? It's a different story. So cases, fully edentulous cases, or cases almost fully edentulous like this one with pre-existing implants. This patient came with these implants already in her mouth. Focusing again on the upper arch, we decided to extract the posterior right implant, but to maintain the implant in the upper right canine. All the rest of the teeth would need to be extracted, replaced by implants. Of course, this case, almost fully edentulous, some roots couldn't help us to have a digital wax up, so we needed to build up everything from scratch. Base plates with wax rims and a face bow again. You have to, of course, do a setup of acrylic teeth, test them on the patient, verify that this is what you want, this is what you need, and then you can really start with your digital part. So this is the first phase was analog, and then we introduced the radiopaque markers that I mentioned already. Scan the patient, and these markers are visible in the dental scan, very important to have points of reference during the superimposing of the digital files of the dental scan and the STL. This is on your right, you see the STL with the base plate and the prosthetic plan, the digital wax-up. This is a wax-up basically. You see 4 implants here, plus the 1 implant that we would maintain in the upper right canine, 5 implants in total. 1 implant pre-existing, 4 implants to be placed through this surgical guide. Very important part, already mentioned, how do you design and how do you fabricate and how do you test on the stone model that you see here, the metal framework with rings in the areas of the implants. And of course, veneering with acrylic teeth and preparing ourselves to go to the surgery and finish the case. Very, very controlled again, this surgical guide, supported by the already existing implant and a couple of more abutments, 2 PI implants and 1 tooth. We placed the 4 implants, great primary stability, flapless again. We had a lot of keratinized tissue. And of course, very easy then we could follow with the placement of the provisional prosthesis, pick up the abutments, and as I said, within a couple of hours, you can have this prosthesis ready for your patient. This to me is a total success. You see, of course, in the upper right canine, the existing implant. This is not the implant. It's visible through the tissues. You can see the multiplus abutment, changing the angulation of the implant, correcting the angulation of the implant. This implant, of course, was not placed following a specific prosthetic plan. We needed to somehow make some corrections. Avoiding the sinus slits again, very precise placements. If you do everything right, if you put good things in the box, you're going to take good things out. This is how it works. So to me, overall, as I said, the major advantage of this journey of guided surgery is the fact that guided surgery gives you the case, your patient, the case in your hand. Before going into this guided surgery and guided implantology world, I thought that I was planning my cases. But now I know what is to plan my cases. Now I know that when I enter the surgery, I know everything about my patient. I know where's the bone, where's the soft tissue, where is the prosthetic plan, everything in advance. There is no room for adjustments, for last minute adjustments. You have to have made these adjustments in advance. And this creates a big responsibility for you, of course, but also it creates a big opportunity to become a better dentist. A few take-home messages for you. I know that all this it's very difficult for me to give you practical information on how to do it tomorrow morning in your office, but in 1 hour, my goal was to give you some basic principles, some key points of my perspective, right? So as far as accuracy, to me, this is #1 priority. I would like to do everything in the most precise way. So as far as accuracy in surgical guides, we know that bone-supported guides are the least accurate. And then, of course, mucosa-supported guides have more accuracy, and the most accurate guides are the tooth-supported guides. It makes sense, right? Teeth provide us with a reproducible and reusable stable point of reference for our guide support. It's very important. So if you have teeth, as I said, use them. If you don't have enough teeth, then add PI implants. This is very important. You increase the accuracy of your guide tremendously. And of course, using anchor pins doesn't increase the accuracy of the surgical guide. Of course, we use anchor pins if needed to increase the stability of our guide, but not the accuracy. Anchor pins don't increase the accuracy of the whole procedure. So if you don't have any teeth, you should start adding implants, right? Sometimes we use 4 PI implants in order to execute a full arch case without any pre-existing teeth. How do you produce the STL files? In other words, do you scan your patient's teeth with an intraoral scanner, or should you take an impression and use an extraoral scanner? A very simple answer to this question. In simple, small cases, single implant, short span implant bridges, 1, 2 implants, not a problem if you use an intraoral scanner. If you are dealing with a big case, with a full arch or a full mouth case, I said that already, you need to have a model in your hands. You need to have something to test all these things that you're doing. And of course, increase the accuracy of the whole procedure. If you don't have a model or models articulated, how can you really adjust the occlusion? How can you do everything, all the prosthetic planning in a precise way? I don't know. I mean, I really feel that this is impossible. I know that we live in the era of facial scanners. I know that this is where we're going, and in a few years, I'm sure that this is where what we're gonna do. We're gonna scan the patient's face. We're gonna have an STL of the patient's face, and of course, scan the patient's teeth with an intraoral scanner and go model free. But right now, the phaseBow to me is not something that we can replace. The most important thing, how can you transfer, as I said, the phaseBow registration in a digital environment? Yes, I know, model free, we said that already, but model free means, in my mind, that our patient is also digital in a way, right? And we're not doing this kind of surgeries on a digital patient. Our patients are physical. They're human beings with flesh and bone. So in my mind, before going into this physical patient, I want to have something physical in my hands, a model to test what I'm doing. So as far as the team that you're going to work with, I know that many of you must be feeling like I was in my early days or in my first case that I share with you. So at the beginning, you need people to help you. Of course, you need a dental technician that has experience in this workflow, in the guided implantology workflow, and all the equipment needed. But of course, you need a provider, someone that will give you the digital, connect the pieces of the puzzle, will guide this process. Something to remember, very important. Most of these people that handle these digital services that give you the option to do it guided are at this level. So you say, I'm going to do it guided, and you think that the guy that is helping you is a dentist. He's not a dentist. He's not an implantologist. Most of the times, he's just an IT guy, great with computers, but not really knowledgeable in terms of implant dentistry. So this is something that you have to remember. And of course, there are levels to this. If you work with BEGO, I mean, with a team of the specialists of BEGO, it's a different thing. I mean, they're doing a fantastic job. They can help you reach the highest levels. But even in this case, you are the dentist in this team. You are responsible for the final outcome. You are responsible for the whole planning. So it's very important to take this responsibility. and upgrade your own software, your mind. So you need to really receive training in terms of how can you use all these digital applications to plan your cases and be in charge. It's very important to be in charge of all this. I know that this is not easy because it wasn't easy when I started. So we have, in Immediate Team, we have designed special courses. Of course, we have courses for multiple aspects of implant dentistry, but we have designed a special course dedicated to guided implantology. It's a 1-day or 2-day course. So we have planned it already with BEGO. I don't know if the situation with the pandemic will allow us to really do this course in Bremen in October of 2021. But you know, it's if some of you are interested in this course, you can really get information from the people of BEGO. We would be very pleased to have you there. We're looking forward to meeting you. To have a conclusion in this lecture, we have to remember that we cannot avoid going guided or going digital. It's something inevitable. The digital technology is a big part of our lives in general, right? So we are working with this technology hand by hand. The most important thing is to remember that we are the mind that is creating the artificial intelligence. So the artificial intelligence, the softwares and hardware and all this are just a reflection of our own mind. So we cannot be dependent on them. We are guiding the guides. It's very important. We have to take this responsibility. And of course, as I said at the beginning, you might feel that all this journey is difficult and you're waiting help from outside. You must be feeling like a small musician waiting for the maestro to tell you exactly what to play and when to play. But as you gradually, this is normal at the beginning, but as you gradually develop yourself, you might start to understand that you are the maestro. This is your goal. You are the maestro of the whole process. At the end, you are basically the only one that's playing music in the room. So I would like to thank you. It was a pleasure to give this lecture. As I said, it will be a pleasure to meet you in the future, maybe in a congress or a course. And of course, I'm looking forward to answering any questions that you might have. Thank you very much.
Dear Andreas, dear friend Andreas, thank you very much for accepting our invitation. As always, very didactic presentation. I'm very big fan of your presentation. You can always bring a topic very beginning, middle, end, so with conclusion. So thank you very much for this. We have questions coming. Dr. Bijan, I was supposed to give you for the opening the session, but maybe you can say some words before we start the Q&A, because unfortunately I believe you were offline. Your microphone is turned off, so please you just need to turn on your microphone.
Can you hear me?
Yes, we can hear you.
I can.
Actually, I was in favor of say hello and say welcome to all of the audience in the beginning of the webinar, but no problem. It's a good time to say my appreciation to Andreas for his brilliant presentation. It was a good and important thing in a simple word by him. Thank you, Andreas. Actually, I don't want to waste time. Just I'm in favor of having a discussion about our institute. Implant Research Institute is one of the research institutes affiliated to the Isfahan Dental Faculty, the dental school in Isfahan University of Medical Science. And in this field, the field of the implantology, This is in the behalf of the, I'm speaking on the behalf of the Research Institute of the Implant. Our goal is to have the different research scenarios regarding to the implant in the faculty. And actually we want to have raised the knowledge of the implantology in the faculty, in the city, in the country, for all of the practitioners. Thank you again. I'm here for any comments if you have. And thank you again, Andreas and Marcio. And thank you for all of the participants, my dear friends and colleagues. Thank you.
Thank you, Professor Bijan. We had during the lecture some raised hands. I don't know if it would be questions. Just remembering that questions should be placed on the question box, and they are coming. So please, if you have questions, just place it on the chat box, on the question box. I believe now is the most interesting part of the presentation. Andreas, I have one here. How many months you wait until the placement of the final prosthesis when you do full arch cases with guided surgery?
Thank you, Marcio. Of course, this depends on many factors. Can you hear me? You can still hear me, right? Okay, yes. Yeah. Depends on many factors, of course. It depends on if the implants are placed immediately, if the implants, on the size of the implant, and of course on the primary stability. As a mean, we wait for 3 months. Sometimes if we have implants that are shorter, like 8.5s or 7mm implants loaded immediately, I wait an extra month. If I get the primary stability that I need, generally 3 months is the amount of time that I'm waiting.
Thank you very much. Another question coming. If you give,
can I please? Sorry for interrupting. It's something that came to my mind. A very important thing, a very important aspect is to have a prosthesis that can last more than 3 months if needed. So one of the benefits of having a prosthesis with a metal framework is that you can have this prosthesis functioning in your patient's mouth even for a year. So some patients cannot really afford going into the final prosthesis after 3 months. I mean, they have the money to start extractions, implant placements, provisional prosthesis, but then they need more time to have the money and the finances to support the final prosthesis. So if you have a provisional prosthesis that can last, this is a benefit. It's a great benefit, especially in these times.
Yes, I believe you're completely right. Any special diet you give to your patient after placing immediate provisional prosthesis in full arch cases or bridge cases?
Well, I certainly say to the patient that this is not the right time to start eating very hard things, you know. I believe that immediate loading is a safe procedure. So I don't feel that for the first 3 months until the implants are integrated, the patient should be on a soft diet. I don't believe that. But without going to the other extreme. So I say to the patient, be conscious of how you function. So don't overdo it, but also don't eat soups for 3 months.
Okay, thank you. Well, there is one big here that came and then put the other a little up. So one more coming. How do you superimpose the Facebook data on a STL file?
Yeah, this is a good question, and I know that many people have a problem. Many colleagues have a problem in this phase. we're using a phasebow that allows this transfer in the very, very accurate way. We're using the Cois phasebow, so with the Panadin articulator, okay, this is the analog articulator, but the Cois phasebow has some plastic trays, individual for each patient that we use this phasebow. So you can use this plastic tray that has the silicon index with the patient's teeth, of course. And this plastic tray allows you to transfer the horizontal plane and the midline very accurately in the digital articulator. Very difficult to say practically how we do it, because we have to show the whole process. But yeah, using the Cois phasebow and these plastic trays, horizontal plane and midline can be transferred very accurately.
Thank you very much. Some congratulations from some friends. First, Mrs. Virenda Shukla is our distributor partner in the Emirates. I'm missing him very much. I was supposed to see him next February in the ADEC in Dubai, but we're going to see in the middle of the year. ADEX postponed. Shukla, nice to have you here. Say thank you, Dr. Andreas. Lecture was just super indeed. Our
You're
colleague, dentist colleague, she's just starting with us, a very nice lady from France, Dr. Monica Tsimianek. Monica is, just made her first case of guided surgery, sent us some photos, and was a very nice case. And she said, thank you for your lecture. So hi, nice to have you here, Monica. Then Dr. Vida saying if this webinar was recorded, and maybe she'll be able to view it. Yes, we recorded the webinar. Dr. Andreas was so nice to let us share in our media center the recording of the webinar. So Dr. Vida wasn't able to connect in time. I would be glad to watch it. You'll be able to. Dr. Benas, thank you, Dr. Andreas, for excellent presentation. And thanks, BEGO, for the connection. Another question come from Dr. Ilkea. First, thanking you for the great speech. For edentulous jaws, do you prefer pins for guide stability? I know you said something about the professional implants. Can you just return a little back to the topic, please, Andreas?
Yes, if we have a fully edentulous case, of course we use pins. I use anchor pins even when we have teeth, but we have a free end surgical guide. So in one part of the jaw, if we don't have a posterior abutment, a posterior stable tooth supporting the guide, let's say that we have all existing teeth from the area of the upper left second molar to the lower right canine. So teeth 27 to 13. And we're missing all the teeth in the back in the posterior right area. You can have a guide that's very accurate, but this guide might not be so stable. So you could add an anchor pin in the posterior right area to gain more stability. If you have an edentulous case, of course, you need to increase both. You need to increase both the accuracy and the stability. In these cases, we add provisional implants, PI implants in advance, so that we have a reproducible position for the guide and the provisional prosthesis. This is very important. The provisional prosthesis also has to be placed three-dimensionally in a very precise way. You just don't put it wherever you want. You have to have a precise position. That's why we use the PI implants. So we add PI implants in advance, we have the accuracy needed, and then we add anchor pins during the surgery in order to increase the stability.
Thank you very much. Yeah, another very good friend of ours, Dr. Shaham Taherian from Iran, very nice colleague doing fantastic clinical cases. Thank you very much, Marcio, and thank you, Dr. Andreas, especially to Andreas. Very good and practical in a simple way. Here's a comment, which I believe, knowing Andreas, I have a comment. Guided surgery is the future of implantology, but remembering that is not the replacement of an expert hand and all of Caesar, not guide surgery case, so to say. So yeah, so Andreas.
I fully agree with this comment. And when you start this journey and you start treating cases, especially complex cases with surgical guides, you would see that there are things that you need to adjust during the surgery. Even when using a surgical guide, you have to do sometimes adjustments, and these adjustments are not easy for a beginner. These adjustments are difficult even for an expert. So as I said, you have to grow with your cases, you have to grow with your experience, and of course nothing can replace your expertise, your hand skills. I fully agree.
Yeah, I like to say, if you allow me, Andreas, I like to say, thanks God, we are getting almost to the end of the era when the colleagues say, oh, I am so expert that I don't need a guided surgery. I believe guided surgery, as Dr. Shaherian said, as you said, is a tool, and a tool that we need to use. I used to make like a comparison saying, in fact, we would not need emails. We could still send letters. We will not need an iPhone 12. We had the iPhone 3. So it's the evolution and how to use this evolution, so to say. We will not need computers. We had typewriters. So just using the evolution, as you put in your lecture, yeah, but of course we need the learning curve, and not for every case, but it's nice to have the tool and the evolution.
It's, to me, it really changed my whole practice. The greatest benefit, as I mentioned, is the fact that I now feel better. I am planning the cases in a more responsible way, because I don't have an option not to do. When you feel very skillful and confident with your hands, you might say, okay, there's nothing that can happen that I cannot manage, right? So let's do the surgery. If you have to plan and follow a guide, then you really have to take your time, calm down, connect all the details, and know your case. So this is the part of guided surgery that I like the most.
Very nice. Also for Dr. Maliha, she asked now, how do you superimpose the STL files on the DINCO files?
Well, of course, the software that we use has a special mode for superimposing these two digital files, of course. It's part of the process, and of course, part of the regular digital workflow. Now, if you have a DICOM file that is not clear, because you have, as I said, metal restorations, metal ceramic crowns or bridges, or even amalgam fillings, amalgam restorations, then in these cases, we have these artifacts that make this matching of the files very difficult. So in these cases, we use special trays with markers that allow this matching. We have points of reference that are visible in the STL and the DICOM, and we match them using this point of reference.
Thank you very much. And also congratulations from Dr. Mortaza, saying thank you very much for your nice presentation. In terms of question, at the moment, we don't have any, so we can wait. So waiting if another come, but if not, Professor Bijan, would you have some final words for the audience?
Thank you. I just want to mention that the Implant Systems Center is intended to have a series of presentations. And the Andreas presentation was the first. And actually, it was a very good beginning for our series of seminars. So we will inform all of the audience about the next presentation and about the next subject. Thank you very much and I have to appreciate the cooperation of the Mr. Majlisi and Mr. Shakuri, my dear friends from Iran, from the distributor of BEGO in Tehran. And actually from the RAS for organizing some brilliant webinars. Thank you, Marcio, and thank you, Andreas.
Andreas, thank you, Professor Bijan, for allowing us to making this event together. My friend Andreas, Dr. Barbaceas, do you have final words? I have, just before you say your final words, just Dr. Malih thanking you for asking the question. Dr. Madis, thanking you for the amazing conference. Dr. Pega, also thanking you for the conference. Andreas.
Final words from my side. I'm also very grateful for this.
You are Greek. Watch out with the philosophy.
No. I would be. I'm Greek, but I come from a place that's called Sparta, very close. From a place very close to Sparta, where people were famous for not speaking too much. You know. So thank you very much.
Oh, please. You know me. We know so many years. It was a joke. So yeah.
No, okay. No, it was a pleasure. It's always a pleasure. And this this whole guided implantology journey for me has been amazing from the very beginning. It allowed me to reinvent myself, and I hope that with this lecture, I can also, in a way, inspire people to follow these steps. It will be great for everybody. This is what I believe.
Thank you. Well, as you said, we hope, inshallah, to have the possibility to conduct your course October 2021 in Bremen. It's a very nice project that Andreas and BEGO had together to make the hands-on in the same patient that he shows during this presentation. So the concept is very beautiful. So we hope to have this lecture.
It's Masio, it's this whole discussion about guided surgery can be very theoretical until you come to the point until the time comes and you really have to face the problems, you know. So as I said, in 1 hour it's very difficult to talk about everything. So we have designed a course that allows you to get all the theory that is needed on how to plan a big case, and then all the digital and analog phases that are important to do it in a very controlled way. And of course, how to manage complications, or how to manage things when things are not going in the way that you expect. So yeah, it will be a pleasure if we do it. But most importantly, it will be a pleasure if the whole world gets back to normal. I mean, this is the most important thing, and then we can start thinking about courses.
Exactly. Yeah, I believe this is the final word. As the moderator just saying the final words, I wish you all a very nice and very healthy end of the year. A very healthy 2021. We all, I believe, we all learn in 2020 that healthy contact with friends, family are the most important things. And so, yeah, I wish you all a fantastic end of the year to recharge the batteries, and see you all in 2021 again. As the moderator, I'm finishing the session, and yeah, I wish you all nice end of the day. Bye bye.
Bye bye. Thank you very much.